Congresswoman Bustos.
Thank you, Madam Chair, and thank you, Mr. Secretary, for being here. We appreciate it. So I come from the state of Illinois, where we've actually had some cases of coronavirus. And I actually want to shift my line of questioning, not so much just around appropriations, even though we're here at our Labor H Subcommittee of Appropriations, but more about preparing communities. About 85% of the towns I represent are 5,000 people or fewer, 60% are 1,000 people or fewer, so a lot of small and rural areas. And with the expected increase in cases that we've learned about, what will you and your department do to help prepare our local health providers to be ready for this?
Yeah, and Congresswoman, first, thank you for your leadership on rural health, and really appreciate you coming over and meeting with me.
I appreciated you having me. It was very nice of you. Thank you.
Yeah. In terms of rural communities and rural hospitals and providers in the coronavirus situation, first, we don't know how broad any spread would be. We prepare for community outbreaks. Those could be really localized, and then taking mitigation efforts. Dr. Ann Schuchat, who's the top career official at CDC, yesterday at our press conference, she tried to clarify one of the misimpressions that people have had from our current active containment efforts. Because right now we're bringing people back from China or from Japan, repatriating them, and they may be positive. We're in active containment. We are using high-end health facilities like Ebola treatment centers as really isolation units for them, even though they don't require that level of medical care, because we're in an active containment. We don't have another place for them to be. So the impression, I think, is getting created that anybody who gets novel coronavirus not only goes to the hospital, but also goes to a very intensive type negative airflow facility, which our rural communities don't have.
Right.
In fact, what she said is most people who would get novel coronavirus are going to stay at home. They're going to treat it the way they would treat a severe flu or a cold, managing symptoms, and we will publish clear information when you should seek medical attention, when you go to the hospital for the rarer instances where that would be required. So part of it is really managing that patient flow so we don't collapse our rural hospitals unnecessarily. So it's really important that we all work together to educate the public and providers about that.
So it's really no different in rural America than urban America. It's just educating the public on how best to treat this rather than head to the biggest hospital.
That's right. Don't race. It's not going to be racing to the emergency room, right? But also the state and local support in the SUP will, of course, be really important for our hospitals and local public health agencies.
Okay. All right. Thank you. Let me shift to the discussion that we had when I was in your office back in November, and that was about healthcare provider shortage. So I'll give you an example in the congressional district that I serve. We have a county, it's called Henderson County, where the patient-to-physician ratio is 6,995 patients to one physician. That contrasts, like if you look at Cook County, in our largest county in Illinois, we're Chicago area, the ratio there is 1,200 to 1. So, and then you've also have these example, we have a hospital that literally took 7 years to recruit a physician. So, we talked a little bit about this before, but we worked together, my colleagues and I, in last year's funding bill to direct the Health Resources Services Administration to provide a report to our committee within 120 days of how recruitment could be better handled to address these provider shortages. And so I did note that in the president's budget, his proposal is to cut the healthcare workforce program by $824 million, or about 50%. And so I was just wondering how your department will square that massive cut with ending provider shortages, or at least addressing provider shortages, especially in rural America.
Yeah, so I understand your concern and your question. The program that we fund there is the National Health Service Corps, which really lets us, through tuition reimbursement, get people who are nurses, doctors, dentists through a reimbursement system to serve in rural communities and underserved areas. The other program, the one you mentioned that we propose cutting, it doesn't have demonstrable results in terms of producing that kind of service in rural and underserved areas. It more goes to institutions as subsidies around teaching. The other thing that we want to do is reform our graduate medical education program. That's why we advocate combining the Medicare, Medicaid, and children's graduate medical education programs and getting rid of the caps that we had from the 1990s that freeze in place specialties so that we can enhance our primary care doctors that we produce and psychs and other underserved specialty areas to get them into rural areas. That's part of the plan also.
Okay, I have like several follow-up questions. I can get those to you later because I'm out of time right now, but thank you for being here and thanks for your answers.